Hi, welcome to this session. My name's Emma Gordon and I'm the Director of the Administrative Data Research UK programme at the Economic and Social Research Council. I'll be chairing this afternoon's session, which will be looking beyond health data to hear about some fantastic cross-sectoral projects that are going on to inform both this phase of the management of the pandemic and also how we build resilience into the system of evidence-based decision-making for the future. So we'll be hearing from Ruth Gilbert from UCL about a project she's leading to link education outcomes data to health data, and Andrew Engeli from the Joint Biosecurity Centre about wastewater monitoring as a data innovation in the time of COVID. And Mark Green from the University of Liverpool will be talking about a project he worked on to help inform local authority decision-making around the COVID pandemic. And Nicola Perrin from the International COVID-19 Data Alliance will be talking about how we demonstrate trustworthiness in cross-sector data sharing. So we'll start by hearing 5-minute presentations from each of the panelists before we move on to questions that I will ask the panel before I open up to panels questions from the audience. So please do submit your questions as we go through the talk so that we can pick these up at the end. So to my first speaker, Ruth, do you want to fire away?
Yep, thank you. I'll just share my screen. Is this working? Can you see it?
Yes, all good.
Okay, thank you very much, Emma, for that introduction. So eChild is a new database that links hospital data, education and social care data for 14.7 million children in England. eChild follows children up to their 25th birthday at the start of the pandemic, and we'll be following them through into adulthood as more data accrues across years. So the eChild data contains education data, and this includes school records for all children attending state school, including the type of special educational needs support that they have, absences and exclusions. The database also contains scores from 5 standardized tests. So yes, we're very tested in England, well in the UK as well. And these are tests that occur at 5, 7 and 11, and then public examinations that take place at 16 and 18. So we estimate that over 95% of all children in England will have records in this database at some point, although some spend some of their time in private schools as well. So it also contains all NHS hospital records for children in England, and this includes 97% of all births that take place in NHS hospitals, and then subsequent admissions, attendances at accident and emergency and outpatient departments, and deaths. So our linkage so far shows that 99% of children in the education data link to at least one hospital record. And this is true even for those who are too old to have been born in this data set. So they were born before 1997, over 92% of those linked. So we were surprised at this, and it means that hospital contacts are really very common over the child life course. So the third database that has been linked so far is children's social care. So this is a statutory service for child safeguarding and child protection across England, and it records all referrals, all services, child protection orders, and all placements into care. So around 25% of all children receive social care services between birth and 16 years, and around 3% are ever placed in care. So provision of social care and education does vary across the country, and it has changed over time as policies have changed. So this creates opportunities for us to explore the impacts of education and social care interventions on the health of children who have similar phenotypes or similar characteristics. So one set of characteristics that are really important is age, because childhood is a time of really rapid development. So in the top left here, you can see the gradient of test results for attainment tests in 1 year. So 65% of the oldest children in this school year who were born in September reached expected attainment levels, compared with 40% of the youngest in the year. And you see that repeating across year over year. We see the same pattern at age 11, at age 16, and for special educational needs provision. And similarly, age really matters from conception. In this graph, you see that 60% of children born at 24 weeks of gestation do not attain expected levels when they turn 11, versus 20% of those who were born at 40 weeks. So what these differences suggest is that these scores discriminate quite well between relatively small developmental differences across groups of children. And so we can use these measures to define, for example, prognostic groups, or to evaluate healthcare interventions that might impact on cognitive outcomes. So eChild will be really important, particularly for investigating multiple vulnerabilities. So for example, in this graph, we see the combination of children with special educational needs and in contact with social care. So 83% of children who are ever in care also have special educational needs, and 2/3, 65% of those who are in contact with social care but not placed in care, versus 34% of those never in contact with these services. And what eChild is currently being used to do is to compare healthcare contacts among vulnerable groups like these before and after the onset of the pandemic, to quantify delays in diagnosis, delays in planned care, and to estimate and potentially mitigate the harmful effects of lockdown, particularly long-term harmful effects. So lastly, I just want to say that eChild is a work in progress. It's supported by this partnership across government and academia, which is committed to making this database more widely available for approved research projects. Thank you very much.
Thanks very much, Ruth. Really interesting talk, and great to see some questions coming through already. So we'll pick those up at the end, but if we could move on to Andrew's talk now. Andrew, fire away.
Terrific, thank you, Emma. And I will just share my screen as well with everybody. So just take 1 second there. Hopefully everybody can see my presentation.
Yeah, that's great, yeah.
Yeah. Terrific. So real pleasure to be here today. I'm Andrew Engley. I'm the Deputy Director for Innovation and Partnerships, but also for the Environmental Monitoring for Health Protection Programme in the Joint Biosecurity Centre of the new UK Health Security Agency. And what that means in a nutshell is that I lead the wastewater monitoring programme. What I wanted to do today was just give you some very quick insights into the wastewater monitoring programme. It's quite interesting in and of itself, but actually really from the perspective of data innovation. So the big broad framing is that as we, the Joint Biosecurity Centre, stood up in May of last year, we began to realise that we might not only be able to acquire data sets that were already in existence, or help other agencies collect data, but also there was a piece of thinking to be done around generating data to give us insights into things that the data sets themselves didn't actually exist for. I can give plenty of examples, but the wastewater monitoring came out of a piece of thinking that we did around prevalence. And what actually is prevalence? As anybody in the health field knows, prevalence in the time of COVID has been a really hot potato. And so wastewater monitoring as a set of activities, but as a set of data, came out of that consideration. So what is wastewater testing? In a nutshell, wastewater testing involves taking samples out of wastewater, as one might imagine. Most people begin viral shedding through their feces in about the first 24 hours of acquiring the disease, for both symptomatic and asymptomatic cases. So what that means is that we can then detect those viral fragments in the wastewater itself and generate insights from that. So currently we're testing around 500 sites in England, which covers about 40 million people, which is about 70% of the population. So wastewater has several distinctive capabilities. I'm not going to go through all of these, but obviously it's fairly low cost and non-invasive. But from a data perspective, it obviates community testing bias. And given that we're also picking up symptomatic and asymptomatic cases as well through wastewater, you can begin to see that it potentially is an unbiased estimator of overall prevalence. And that's what I'm going to just focus on for the last couple of minutes. And we're doing lots of other things, and I can talk about those as well. So we can actually sequence, so we can do metagenomic sequencing, we can detect presence of mutations, variants of concerns, those sorts of things through wastewater. But for the purposes of this short talk, I'm just going to focus on the question of prevalence. So looking at prevalence, our modeling looks something like this. And one of the things that we very quickly learned in a data innovation space is that interpreting those data is quite difficult. So even when we provide wastewater data to experienced health professionals, so local directors of public health, people in the National Incident Response, it's not always particularly easy for them to understand the data and what data means. So one of the things that we've understood is that in the world of data innovation, you have to provide kind of insight. It's not really the data that people are after, it's the insights the data provide. And we've had to do a lot of work around building up a reservoir of knowledge and expertise that can help people do that. In terms of prevalence estimation, how good is wastewater data? I'm just going to show you two graphs here. The solid line represents data either from test and trace pillars 1 and 2, or from the COVID infection study, which obviously is considered to be the gold standard of prevalence estimation. I'd like to say outside of wastewater. And you can see that we've begun to build models that very accurately show the co-termination of wastewater data with prevalence insights that are generated from either of those two sources. This one's quite interesting here. So if we are able to model prevalence through wastewater and demonstrate that against existing data sources, what are the advantages of wastewater? This graph just shows the shift between the two data sets when we run the training models on them. And there's basically no shift with the CIS, which means that we're, in essence, our sampling provides about the same insight at about the same time as the ONS data, although I would say that we actually generate our data about 7 days before the ONS data are actually published. But in terms of a shift on the test and trace data, it's about 8 days. What that means is that we are able to estimate prevalence 8 days before the test and trace data are picking up those same changes in prevalence or incidence in their modeling. So one can quickly begin to see that we've built a rather innovative source of data that is beginning to provide sort of leading edge indications of what's going on with prevalence. We have quite a few challenges, and I'm just going to sort of end there. But one of the tricky things about working in an innovative data space is that it's not as simple as just taking a classic data set, manipulating that, and providing robust insights. So we've got a lot of issues with what we call levels of detection, which in the popular parlance would be termed false negatives. The graph on the right just simply shows the wide range of factors that can actually influence the outcome side of the data set. We've got problems with insights, as I've just said. So whenever we do provide wastewater signals, the first question that everybody asks is, well, how many cases are there? When we say we think we found wastewater in a town of COVID in a town of 15,000 people. And the answer is, well, at the moment, we really will operate on it's there, it's not there basis. But we're beginning to generate quantifiable or quantitative modeling, and we're actually moving towards sort of confidence-bound estimation of how many cases we might think are present in an area if they've not already been detected in clinical testing. And then the last one's really interesting, and hopefully this can provide a little bit of room for conversation. It's often misunderstood in the world of wastewater data that we are not actually looking at anything personal. So although the viral fragments get into the wastewater through feces, the feces actually dissolves. And if we do find it in our samples, we discard it from our samples. So we look at nothing human. We discard any trace of DNA from our samples. We only look at the virus itself, the viral fragments, the RNA fragments. So it's a really novel data source, and that puts us in a really interesting space. From a legal perspective, these are definitely not personal data, and we've done a lot of work around that. But what does the public think about that? Just because it's legal doesn't mean to say that we have either implied or explicit consent from the public to do this. And so we're doing a whole piece of work, which is being led by Ipsos Mori, and I think the results will be published very shortly. We've been conducting a large-scale public deliberation with a citizen panel of 100 citizens to explore conditions of consent for wastewater usage. So that last one for me, I think, is really interesting as we begin to think about what is a novel data source and how do we use that in the administrative and the policy space. So I'm going to stop right there and hand it back to Emma.
Thanks very much, Andrew. And like you say, hopefully that will generate some really interesting questions coming through from the audience. So Mark's due to talk next. I know he was having some problems linking into the session, but can I check if Mark's there now?
I am here. Thanks, Emma.
Excellent. Fantastic, Mark. I'll hand over to you. So if you want to share your slides, I'll tell you when I see them.
Excellent, thank you. I think someone's going to share my slides on my behalf as I'm dialing in off my phone.
Right. Excellent, and very glad you could join us. And yeah, there we go. Over to you, Mark.
Okay, so I'm going to describe local data spaces in about 5 minutes, or at least try my best to do that. So can we, next slide, please. I think these are the previous slides, sorry. So I think these are the wastewater ones. It needs to be the local data spaces slides, please.
Do bear with us, minor technical hitch. Be with you in a sec.
Perfect. Thank you. Sorry about that, everybody. Okay, next slide, please. So what I'm going to do in hopefully for 4 and a bit minutes now is explain what local data spaces is and just talk about some of the key outputs of what we found. Next slide, please. So local data spaces was set up in a very short period of time and only lasted for 6 months. And really it was about trying to test whether we can open up and make secure data from trusted research environments, focusing mostly on the ONS Secure Research Service. Could we open up and make them accessible to local authorities to help them provide timely, important data for their responses to COVID-19? And we were set about doing this in 3 ways. Next slide, please. So the first way we did is we spoke with a lot of local authorities, we arranged meetings with them, and where we identified that they had sufficient needs, resources, we helped them put in an application to the SRS. So we worked them through that stage, helped them submit that application, talk through the data requirements. And this allowed local authorities to conduct their own analysis themselves, access these data that they wouldn't normally have, and actually do things very differently to how they kind of go about their evidence gathering process. So for example, we worked with Hackney, who were really interested in using the COVID infection survey to look at occupational inequalities, and we explained what that data were and how to use it. Next slide, please. The second approach was that where we talked to local authorities, but we found that actually they didn't have the time, the skills, the resources to really engage with these data directly. We would co-produce research questions with them at the same time, and then we would go and complete those research questions, do the research on their behalf within the SRS, and then we would take those results, analyses back to the local authorities, and through an iterative approach, use them as sort of conversation starters to what they wanted to get out of this. And this allowed local authorities to indirectly gain data insights from data they wouldn't necessarily have the time, capacity to actually use which is really good and really important for them. But we also took an approach that if we could do it for one local authority, we could do it for every local authority, and we could build replicable code pipelines that would reproduce everything for all local authorities. So for example, with York, they were really interested in how tourism was being impacted on their city. Market Harbour were really interested in the impacts of retail footfall on their high streets. And we also submitted evidence to Liverpool's evaluation of the mass testing pilot. Next slide, please. The third approach was where we would generate these analyses, we would put these out as reports for each local authority. And we would share them with local authorities and use that process to gain feedback, which would allow us then to refine iteratively those reports, make them better. And this would then allow us to produce more finalized or new reports based upon those discussions that we had with local authorities. So for example, we talked to Hull. So we went and gave a presentation of Public Health England's North East and Yorkshire group. And Hull saw our report on occupational inequalities in COVID-19. So that's really interesting. Could we do it? But answering these questions, which allowed us then to produce new reports, and they gained data insights on data that they hadn't even touched or really been part of that process. Next slide, please. So we worked with about 25 local authorities, and with those 25 local authorities, we ended up producing or co-producing 10 short reports, which are freely available on this link on the CDRC website. They're produced for all local authorities in England, and so far we've had about 250 downloads of those reports. We also managed to produce 6 more bespoke reports, which were based upon local authorities' sort of needs and those discussions with those over exactly what they wanted. And we were also flexible in being able to produce evidence for national calls of evidence, including working with SAGE on some of the occupational inequalities work. And we did this all within an open source framework using computational notebooks within R, so that local authorities themselves could replicate all of the analysis that we did, which would at least help either upskill their research team, or at least provide some critical route into evaluating and evaluating what we did. So hopefully that's about local data spaces in roughly 5 minutes. Thank you very much for listening, and I'm happy to take any questions later on.
Thanks very much, Mark. And that was a great whistle-stop tour of a fantastic project. Nicola, should we go on to you next before we open up to questions?
Thank you very much, Emma, and thank you for inviting me here today. We've heard lots of fantastic examples already today about cross-sector data sharing, and there are many more that one could add as well. For example, ICODA, which you've all been hearing about today, the International COVID Data Alliance, has a driver project that is looking at the impact of lockdown on premature and stillborn births. They've started with clinical data from a large number of countries across the world, but they want to move on from just using clinical data to expand to look at the impact of socioeconomic factors and issues like nutrition and pollution, to try and unpack that why lockdown seems to have had different impacts on premature births in different parts of the world. So that's another example of why it's really important to be able to bring together data from lots of different sectors. But I wanted to actually stand back a bit today and think how we can make sure that we can use this data in a way that's trustworthy. And so I was going to do that by exploring 3 questions. The first of which is what we really mean by cross-sector data sharing. And one of the key things is that data has been collected for one purpose, but increasingly we're able to see that being used for another purpose. And we see that a lot with health data at the moment. I think it's no longer just your patient record, your GP record, or an X-ray or a path report that gives information about your health. There's a huge number of other sources now, whether it's wearables and Fitbits, voice recognition, mobility and gait data, sleep patterns, information about what you eat, what you buy from supermarkets, the sort of loyalty card data, social media data, GPS data about locations, and even, as we've just been hearing, the sort of wastewater and sewage data. So Ada Lovelace have published a report recently, The Data Will See You Now, and that looks at the implication of the increasing number of different data sources that provide information about our health. And I think it's really interesting to start thinking whether or not we need to be able to practically or legally define health data. What does it mean for who can access it? What are the rules for that access? And so that brings me to my second question, which is how people feel about cross-sector data sharing and different types of data linkage. What do we know about public attitudes on this? There have been a few studies that have looked at it, but I have to say there isn't a huge amount of evidence that we can draw from. ADR UK actually published a really helpful literature review last year, and that looks at different attitudes to the use and linkage of administrative data. It's based on, I think it was 16 studies over a similar number of years. So I think it's fair to say there isn't a huge amount of evidence. What evidence there is suggests that although there is increasing awareness of uses of data, there's much less awareness or really understanding about what that phrase data linkage actually means. And so that's something that I think we need to all keep working on explaining better to people. When one discusses this with people, there's a number of different factors at play. Attitudes depend on what type of data we're talking about. Health data, obviously, people find particularly sensitive and confidential, but actually when you sort of ask about other sorts of data, it's not always the most confidential data. I think a lot of people think about financial data as more sensitive to them. Location data can also have privacy implications, particularly if you're linking, for example, location data and credit card data. Garmin data, there have been lots of examples where people uploading their cycle routes or their jogging has actually sort of revealed information that they probably wouldn't want revealed about where they live or run to and from. And even something like an energy meter, your smart energy meter, when you first think about it, it seems completely fine, but actually that can give a lot of information about whether you're in or you're away on holiday, what the security implications, what about people knowing your usual routines, and the changing patterns when somebody makes a cup of tea or has a shower can actually be used for early warning signs of old people not following their routines, or even warning signs of people who might be at risk of suicide. So something like a smart energy meter can give us a huge amount more data than one would perhaps expect. So that's one bit that people are interested in. Also, obviously, what the purpose of using the data and linking the data is. Is it for individual benefit, for your own care? And in that case, I think people generally think data linkage when it helps them is okay. The other thing that perhaps surprisingly comes through consistently from the attitudes work is that it's also, people think it's really good to be catching fraudsters. So if you're linking data to catch fraudsters, that's all good. Much less certainty when it comes to research purposes. And here that really does depend on what the research is about and whether there's a public benefit. And then the other main kind of question that people want to know about is what the safeguards are. Who can access the data? Is the data identifiable? How is it kept safe and secure? And so that brings me to the third and final question. What do we need to do to make sure that cross-sector data sharing is trustworthy? And so a kind of list of things that we might want to think about, and this builds on work Understanding Patient Data have done about what makes uses of data trustworthy, and also links in with the 5 Safes framework. And I think the kinds of things that we need to think about is, what's the purpose of using the data, and is there public benefit? And within that, there are lots of different views about what actually counts as public benefit. How do you describe that? And the National Data Guardian is doing some work at the moment to try and define that. Who's involved? Is there commercial access? And what does the governance look like? What are the rules about access? Who decides? And are public and patients involved in that decision making? That's obviously one of the really key things that is increasingly becoming part of making something trustworthy. How are people kept informed? And is there transparency? And that sort of trust and transparency came out really clearly in ADR UK's systematic review of the literature so far. And finally, how's data kept safe? Are there trusted research environments? And what are the implications when data comes from lots of different sources into one single environment? And that's actually something that ICODA is also really been thinking about how can we bring together data from multiple sources, and does it need some new model of data stewardship to begin to make sure that that's done in a really trustworthy way that people from across the world can have confidence in. But I'm happy to discuss that in more detail during the questions, or I think there is actually another session on stewardship straight after this one. Thank you.
Thanks very much, Nicola. That was really great talk. So if all the panelists could just turn their cameras back on, and we'll kick off with the questions. So I've got a few of my own, but just because we're a little bit short of time, I'm going to try and wrap my questions in with some from the audience as well, just so that we can get their views heard as well. So Ruth, going to you first. Your project's a great example that demonstrates the scientific value of data linkage across sectors. My question is going to be, how do you think this could be developed, either through further research using the linked database that you created, or through further linkages? But then noting one of the questions from the audience, could this track children with autism or learning disabilities or ADHD? And what about home educated children?
Okay, loads of questions in there. So the last bit first, autism spectrum disorder, we can track in the special educational needs, and to some extent in the health data. Hospital data is less good than primary care data, so GP data, at characterising autism and ADHD. But because we have a whole sort of chronology, we can pick it up to some extent, but not perfect. Okay, so Emma, your questions. Can I take the one about further linkages first? I mean, this is a vast database and it's extremely rich and brings these three services together. But it's about individual children, and in health, in social care particularly, and in education, we know that families are really important, and that parental health is really important for parenting capacity and for children's education. And so I think the first step would be to be able to do a de-identified linkage of mothers. That's something we can do and do routinely in health data, and siblings. This is something that's used across the Nordic countries. So sibling controls are routinely used to take account of unmeasured shared environmental factors. And it's something that we could do in this data set without really additional risks. So that's what I'd like to see before we go further. And I think the practitioners that deal with these families would also be really interested. In terms of how we could extend this through research, I think there's really big questions here. We think that education is really important. Well, we know it's strongly associated with lifelong health in adulthood and with adult life expectancy. But there's certain aspects of education that might be really important and benefit certain people. So for instance, what are the causal effects of providing special educational needs support? These are vulnerable kids who might particularly benefit in terms of additional independence and self-sufficiency and learning, rather than just education for the whole population. So I think that's one of the areas I'd like to see developed, with advanced causal methods applied to observational data.
Thanks very much. And for all the reasons that you suggest, I think the database that you've created is going to be really insightful in terms of thinking about how we manage the next phase of the pandemic, which is about tracking all of the different cohorts of children with all these different conditions through, and making sure that we can track their educational attainment as well as the broader educational attainment of kids that's no doubt been impacted differentially through this pandemic. But if I go on to Andrew, so thinking about the role that wastewater testing has had in the management of this pandemic and how this has added value to decision making, how do you think this will contribute to our preparedness for future pandemics? And I'm going to wrap this up with one of the questions which it popped up incredibly quickly, so I don't know whether it's actually for us or not, but it's about how are you able to identify care home or domiciliary care residents? So essentially, how specific is your wastewater testing, and how specific do you think it could be in the future?
Well, thanks. That's a that's a great set of questions. Take the last one first. We can actually get quite granular with this, and so that formed a large part of that public deliberation that I was just discussing, is just to understand what the public felt about, as we get closer to buildings or infrastructures or whatever they might be, how does the public feel about that as the site of testing gets closer to your front door? But the answer is that we have already done pilots in several different kinds of infrastructures, including schools, for example. I know more about pooing habits in schools than I thought I would ever know or wish to know, and about gender differences in pooing habits in schools. There are. So we can actually do that. We can care homes, we can do all sorts of things. So yes, we can provide insights from that. The beyond COVID is really important. I think this is an enduring part of our ongoing surveillance capability beyond COVID. And we already know that COVID is just one of a number of viruses, pathogens, so on and so forth. And we can do all of those things just as much as we can do COVID. Our aspiration is to start doing things more in real time, and cut down our cycle times, and we're getting very fast towards having real-time detection technology. All of that sounds exciting, but again, I'll bring us back to the ethical dimension and understanding what consent looks like in that space, in a world where these data are not personal data. We're literally tracking virus in the sewer. It just so happens that it's being deposited in the sewer by individuals. So all of that's immensely promising, but I think what I really wanted to get to for us, I think it's not just an innovation in data, but it's a way in which a new data source can actually then help us rethink the way that we provide health protection. So we talk about public health, and I think one of the agendas that we have is putting the public back into public health. And can one imagine a world in which actually we could provide sort of something that looks like a weather forecast in your area that's actually a health forecast, based on our understanding of how many viral particles of various kinds that we're finding. And if that's not too far-fetched, we think that can be there. And we're already running some behavioral insights trials with the public to understand whether individuals may respond to signal in the same way that we all take the weather forecast for granted, for example. We're working a lot with the Met Office. So, I think for me, that's a great example of data innovation, but, I never want to underestimate the challenge of we need to be trusted, we need to be transparent, and, over and above everything, we need the public to understand that this is not just a safe, the sewers are safe, but their data are safe as well. Actually, it's not their data, but the data do not in any way, shape, or form undermine our right to privacy and our right to control of our own data.
Thank you so much, Andrew. I'm James Pickett from HDR UK. During your response, Emma seemed to drop off camera and doesn't seem to be in the room now. So I really hope we'll keep an eye if she's trying to get back in, but I'm not sure what's happened there. Perhaps she's having connection issues, but I'll just stand in, if that's okay, while we try to get Emma back, and maybe ask a question for Mark. So Mark, in your project, you were supporting evidence-based decision-making at both the national level through SAGE and at a local level through the authorities. Did you get a sense that both were equally placed to make sense of this evidence? Kind of great to see that Emma's rejoined us, but I'll leave the question with Mark. So it's about kind of differences in kind of national and local use of evidence.
Thank you. So I think both local and national government have a range of skills and experiences. And these can range from people who are competent, happy with data, they use it day to day, or they're proficient with analysis, all the way up to down to, or however you want to describe it, people who are terrified or just do not want to deal with data. And these people are at varying levels of organizations. And there's not necessarily a big difference between local and national. And I think what we really learned during the Local Data Spaces project was that you really do need to pitch things at the audience and in terms of these different levels of confidences. Now, it's possible that probably local authorities were maybe a bit less confident because they were, being kind of stretched in terms of their resourcing over the last 10 years for various reasons. They have smaller teams, and they were often in sort of firefighting mode where they were trying to produce daily stats, and they didn't have the bigger headspace to look at some of these broader issues. I think what we definitely learned there is it's really about trying to make resources as easy as possible, and then making them even more easier than you think they are. So, for example, with the short reports we produce, we thought, well, if you bang in a bunch of simple graphs, some description of what they mean, then that would be fine. People will be able to just look at the graphs or read the text, and they will be fine with that. But actually, what was probably more helpful to the local authorities, at least from when we spoke to them, was actually spending time going through with them and saying, this is how you interpret this, and these are the sorts of decisions that you can make from these resources. So it's really about helping people engage with how useful these things are, as well as helping the different levels of confidences. And those sorts of themes appeared at the national level as well as the local level, to be honest.
Thanks very much, and massive apologies for disappearing. I had a random power cut, which happens quite a lot in South Wales. But anyway, back now. Yeah, Nicola, clearly decisions around data access, whether it's NHS or other forms of data, are taken with legal bases in mind, and everyone understands that who works in this area. But do you get a sense that there should be a broader conversation around the public benefit of research involving both health and administrative data, bearing in mind that the public may not understand the legal definitions that around health data or administrative data?
Yeah, absolutely. I think the more that we can talk to people and engage on this, the better. And at the moment, there is a bit of a gap between the legal definition of health data and the amount of data that can be used to give inferences about health. And that gap isn't necessarily particularly helpful, but equally, I don't think the solution is to be much more rigid about what the definition of health data is. I think the more you try and narrow something down by defining it, the more you end up with silos. And one of the things that all this session's discussion is about is breaking down the silos between different types of data sets. So I think we have to get to a position where we can use that data responsibly and trustworthily and everything else for research purposes and for individual benefit. And to do that, you need to talk to people and engage on it and make sure that you've got the right governance frameworks and decision-making processes, but not trying to do it with very complicated legal definitions, I don't think. But engagement has to be the first start.
Thanks very much. And a question to the whole panel. What infrastructure do you see as most important to have in place to enable cross-sector data research going forward? I don't know who wants to kick off first. We'll go in the order that you spoke. So Ruth.
Yeah, I mean, I think secure environments and controls on outputs are really important. Once you get to these rich sort of data, then, it is possible with another data set to re-identify people. You need to protect against that. I really like the idea of Mark where suggests with local government using data in this sort of environment. I think that would be great.
Excellent. And Andrew.
Yeah, interesting question. I'll just try. I'm just try and give an additional observation. I would have said what Ruth said, but she said it more eloquently than I. Just two very quick things. I think one thing is it's not just about TREs, trusted research environments. It's also about interoperability. And so what we have to understand is that, is it easier or better or more desirable to shift the code to the data or the data to the code? And those are the kinds of questions I think we need to grapple with. And what this pandemic has shown us, if nothing else, is that we don't have the degree of interoperability that we need in the architectural space. I think the second thing is just building on something that Nicola said. I think, you know, from our side, one of the observations that we have is that we have a data governance regime that talks about health and non-health data and treats those two things very differently, when in reality, actually, it doesn't correspond to how data are actually used on the ground. And certainly in the pandemic, we found that that sharp distinction between those two sets of data actually was quite a hindrance, not a help. I understand why we have those data governance regimes. And I think the insight that we've got from the pandemic is that we tend to define health data actually not by data which is about health, but data which is generated by our health providing agencies. And that's a slightly different thing, right? And so I think that distinction right there, is it health data or is it just because it's NHS data, it makes it health data? I think that is the thing that we really need to tunnel into and sort of readjust our thinking around the data governance regime. So yeah, there we are.
Yeah, really interesting. And Mark, I know you've worked across a few different platforms in your time. How do you think it's working?
I think probably quite well. I think that there's two things. One is that we probably have all of the data that we need to answer the questions that we need to ask. It's really about getting that data into the right hands, the right people who are ready to make those decisions, and that they are confident in supporting and using that data and interpreting it. The second issue is really having more linked data sets, which I think COVID's been a great example of actually making lots of linked data, doing that very quickly. I think you can focus on infrastructure and data itself, but actually we need to think about how do you turn data into valuable and actionable information. And actually that takes a lot more hard work. It's about encouraging people to use data. So it requires a sort of culture change, as the National Data Strategy outlines. It's about producing adequate resources to support people in engaging data. And those things aren't necessarily, they're a lot harder to introduce than infrastructure, I think.
Yeah, is it anything to do with research culture and engagement is, yeah, definitely, we can't lose sight of that. Nicola, any last insights? We're out of time, so we'll have to make it quick, but fire away.
So I think the thing that the public want to know is that data about them, from however it's collected and whatever it's about, is kept safe and secure, and that there are the appropriate safeguards. And I think the 5 Safes framework does really resonate with people, and that safe settings is important. So I think the quick answer to your question is probably a TRE with all the things that surround that with it.
Thanks very much, and really interesting discussion, and I hope the audience enjoyed the presentations. I certainly did, and thank you very much everyone, and goodbye.